mistakes in non-infectious uveitis also. And for this, we have Dr. Amit Khosla. He's a very senior consultant in Sir Ganga Ram Hospital in New Delhi, and he's in the Department of Uvea and Vitreoretina Surgery. So, Dr. Amit, please.
Good evening. Thank you, Dr. Rima, for inviting me. So in uveitis, there's always the goal to prevent vision loss, and we always worry about the side effects. If you worry too much of the side effects, you will not control the disease. So the common mistake we make is that we tend to taper the steroids very fast, 10 milligrams. So you need to bring it down to almost 2.5 milligram per week before you taper it off. So you take about 3 months if you feel it's a posterior uveitis. Don't try to taper out standard 6 weeks regimens of tapering the steroids. And if at the end of say 3 weeks you feel that the patient still requires about 0.5 milligram per kg body weight, think of immunosuppression, because 90% of the patients will require immunosuppression. So we have learned from rheumatology that we don't control the disease, we want remission. That is, remission means both clinically and on diagnostic you have a remission of the disease. Because if you were to taper the steroid when you have say activity on the FA or on the ICG, you may have a recurrence. So the focused guidelines tell us that an inactive disease or remission is when the anterior chamber cells are less than 0.5. There's a two-step down in inflammation, then you think that the control is coming. It's not remission free. So as mentioned, we always are worried about the masquerades. We are always worried whether it is infective. So I think Rima's lecture on infection versus non-infection was the most crucial one. Sometimes we make an incorrect diagnosis, or we start the treatment too late, or we have inadequate immunosuppression. So everyone who's interested in management uveitis should read this focus initiative. We tell you what is the optimal time for treatment escalation, when should you transit to a non-steroidal drug, and it's preferable to have a multidisciplinary team collaboration. Here's a patient of 35 years who came with blurring of vision, looks like VKH, right? But we checked, the patient was on checkpoint inhibitors, which itself can cause uveitis. So it's important that the history should also be taken before you make a diagnosis. Here's a child who came with recurrent hypopyon and vitritis. Came in like this, and then we did a vitrectomy, couldn't find any organism, but on detailed history, the child had taken part in a fancy dress program where the eye had been hit by a thorn. So it could have been an infection, but we were not able to localize. We did anything. So history is important. So the other controversy we always has TB versus sarcoidosis. Remember that if you do not have active pulmonary tuberculosis or any other lesions, you can give steroids as a first line, then add the ATT. So there is a patient who had tuberculosis a few years back, had this reaction. This patient was put on steroid, added MMF after 3 months, has 6/6 vision. So the inflammatory component of TB or looks like sarcoid can be there. Here's a patient, a 40-year-old female who was diagnosed elsewhere as VKH. You can see the FA, you can see the ICG. Patient was given steroid, had a complete remission, had a recurrence. Came to me with this right-sided granuloma. I started the patient on steroid and methotrexate. The granuloma doesn't disappear. On this, you feel that the right eye is fine, the left eye is fine. So we added adalimumab. Now, if I go back to the previous slide, if we were to see the FA here, it has activity, but the eye. So you can see this patient, this has activity in the right eye. Left eye, the FA doesn't show any activity on follow-up, but the ICG shows. So the left eye was also active. So you have to use all the tools. So if before you stop treatment in a VKH, get an ICG done or an OCT angiography, but ICG is better, will tell you of the active disease at the end of, so otherwise you will lose the eye. Here's a patient who came in the non-biological era who had this picture, vitritis, hyperemic disc, retinal lesion, Behçet's disease. We tried everything, steroid, azathioprine, cyclosporin. We had all the complication. So from 12 to 15, we were burning our hands. We couldn't get the vision back. And ADA came in 2015 we gave, and suddenly the media became clearer. The child gained 1 line of vision. So being aggressive at the right time, then start planning to give steroid intravitally, going to the next level of immunosuppression helps you save the eye. Here's a patient, a staff nurse in our hospital who postpartum had a fever for 1 day, had this lesion. Now, you always worried, is it vasculitis? It is infective or non-infective, post-fever retinitis. So you hold your hands for a few days, you give an antiviral, you give antibiotics to see how the patient is responding. We did every test possible from scrub to wheel Felix. Finally, we did the tap, and we have a PCR test which we normally use for meningitis as all the viruses, and the patient was negative for all. So we started on oral steroid, gave Razimab for the edema, and we did the angiography later. So these patients can later go into ischemia and NV formation. See the extensive NV, despite laser multiple injection, took us about a year to control this NV. Sometimes post-fever retinitis can have vascular and you think it's resolved, but you need to look for NVDs, NVEs, and also sometimes uveitis can also miss a CNVM. Here's a patient just referred to me 12 years, few days back with poliosis. The initial exudative RD diagnosis was diagnosed as VKH. So after 2 months, the patient came with 612 vision on steroid on Azuran. So when presented to us, the vision had 612 and 624. So the child required more immunosuppression, has already developed sunset. So it's already late. You need to increase the immunosuppression early. So we started the patient on adalimumab. This was already the outer retina has disruption. So we sent for a wide field angiography and you see how much activity is still present in the angiography. So we started the patient on biologics. As mentioned, you need to use FA, ICG, you need autofluorescence and OCT angio to be really sure that you have controlled it. You can't do FA regularly. So autofluorescence helps you to make a diagnosis of a healed serpiginous like choroiditis and it's non-invasive. So in summary, you must identify the characteristic, rule out infections, and plan for immunosuppression day one. If you feel that this patient is severe, use the focus guidelines to think that you must, by the third week, start immunosuppression because after 3 months, the steroids are going to take a toll on the patient. Here's a patient, 2002, I had just bought the digital camera. So this patient was diagnosed as a CRAO type picture. We did the fluorescein, had vasculitis. Patient was given methotrexate, went through all highs and lows of steroid-induced depression to aggression and side effects, but the patient still comes back after 20 years and has 6/6 vision. So patient was put on methotrexate for 2 years and you find the resolution. Now this patient came to me, was a VKH, well resolved, was having intolerance to Azuran. I started the patient of MMF, but I overlooked the pigment. I didn't do the ICG. I felt, oh, the FA is normal, the OCT is normal, clinically patient is 6/6. And see how gradually it started to become fainter and fainter until developed a sunset syndrome in both the eyes. So you can see, if you see the photographs from the beginning, the change is occurring and I am overlooking the change every visit for 5 months. So if I had ICG or I referred the patient for ICG, I would have picked it up. So the patient is still on ADA. I started ADA at this point. The patient is 6/6 even after 2 years. So you have to be aggressive and you have to think at the right time the patient requires an increase in the immunosuppression. Here's a patient who came with pan-uveitis in the lockdown with total posterior synechia, rule out tuberculosis. This is what the child had. So in children, you tend to stop steroids within 3 months, all topical and oral because you don't want to scatter and glaucoma. So you can see how the child resolved and has 6/6 vision. Started the patient on adalimumab at 3 months. So it's important to understand when to introduce the DMARDs, which one to use, when to escalate. And the commonest mistake we make is that we taper the steroid and we start the immunosuppression late and you have a phase of time when you have patients who have recurrence and you think, oh, was my diagnosis right? So for those who are interested, do go through the focus guidelines. I won't go into detail, but it's important to understand that macular edema is not an urgency to treat. You can take some time to make a diagnosis. And these are the indications in that article which tell you. And the most important thing is that now that people are using biologicals, I'll just end my talk saying you must talk about family planning with patients who are on methotrexate and MMF. And all immunosuppression take time for them to act, and you must have the patience to plan and wait. So before you stop the immunosuppression, wait 2 years at least before you start to taper the drugs in severe posterior uveitis. So especially those who have anti-TNF, sometimes you feel that those are not acting. So you can increase the dose to adalimumab to weekly. You can switch to other ones because sometimes you have an antibody formation, golimumab. You can start, or you can combine with other drugs, or you can do a local treatment. So finally, it is not a stepwise. You can jump from one step to the other when you're using immunosuppression, and you can use Intermittently, the steroid implants or something when you feel that it is not responding, but don't use it as a single treatment because they only work for 3 to 6 months. Thank you so much.